Hello and welcome to today's webinar, Addressing Challenges with Infection Control Practices in Ultrasound. My name is John Burdak and I'm Head of Clinical Affairs at Nanosonics, and we're very excited to have you join us for our first educational webinar in Canada. This webinar brings together information on guidelines, research and current issues in ultrasound probe disinfection. Ultimately, we're aiming to help you evaluate and probe infection control issues in your facilities and to implement best practice reprocessing. So our learning objectives for today are to review current ultrasound reprocessing guidelines in Canada and their clinical application, to understand the risks associated with inadequate infection control practices in ultrasound, to gain awareness of new research and global trends in ultrasound probe reprocessing, and finally, to identify the practical considerations for implementation of ultrasound reprocessing workflows. So we are delighted to have Merle Steele-Rodway join us for our webinar today. Merle will be presenting an overview of ultrasound probe reprocessing in Canada. I will then follow on practical considerations for reprocessing workflows in ultrasound, particularly in light of the rapid expansion of ultrasound probe use throughout healthcare facilities. We will follow with a Q&A session at the end. You can type your questions into the text window that should be visible on your screens now, and we'll try to address as many questions as possible. So firstly, I'd like to introduce our expert speaker for today. Merle Steele-Rodway is a nurse consultant with more than 35 years of experience working in Newfoundland and Labrador and has received many awards throughout her career. She's held several roles, including coordinator of the Infection Prevention and Control IPAC program and regional director of both IPAC and medical device reprocessing. Merle is a founder and current president of the Canadian Association of Medical Device Reprocessing, otherwise known as CAMDA, and is a member of the Canadian Standards Association Technical Committees for Medical Device Reprocessing Standard Reviews. She was a CSA committee member that developed the only Canadian certification for medical device reprocessing technicians. Merle has also served as president of IPAC Newfoundland chapter and has received several awards during her nursing career. Merle recently retired from the acute care setting as a nurse consultant in the IPAC and MDR fields. Merle, we're delighted to have you here today, so I'd like to pass it over to you to begin your presentation. Thank you.
Okay, thank you very much, John, and welcome everybody. I'm in Newfoundland, as you know, and so it's 8:30 here at night, so I'm very excited that we've got so many people on the line. So I'm just going to get right to this and talk a little bit about a general overview of ultrasound reprocessing in Canada. Of course, realizing that in a 1 hour or 25 minutes, it's difficult to put everything into the focus, so we'll just move forward. And thank you to Nanosonics for inviting me, and of course also to Gail Schultz. She's a MDR director in Winnipeg Health Authority. We both have done some presentations on this topic, and so I just want to put out some thanks there to her. So the objectives for my presentation are to discuss different types of ultrasound probes, discuss Spalding classification, discuss the ultrasound probe reprocessing issues, discuss Canadian and some other reprocessing guidelines internationally, and then I'll provide a summary as well. Some of this information you may already know, and it'll certainly just add to your knowledge and information. So common ultrasound procedures and probe types. Well, we're all familiar with the transvaginal procedures. We've got transrectal procedures, and there's also the transesophageal procedures known as TEE. I'm not sure, I don't think many sonographers are totally involved with TEE procedures, but certainly the cardiac group would be. And when you look at the surface probe procedures, we've got the ultrasound, abdominal ultrasound scans that are provided with intact skin. Then, of course, intraoperative. So our ultrasound scanners are used in the perioperative areas, in the critical care areas. Also, they're used for interventional procedures in the emergency departments, could be in the ultrasound departments or in critical care as well as the OR again. And they could be utilized by sonographers, technologists, or physicians. And then, of course, ultrasound use on broken skin when some of the clients who have wounds and scars, and there also have some ultrasound procedures done there. So there's a diverse range of ultrasound procedures, and they're performed in a variety of healthcare settings by different end users. So just to talk a little bit about Spalding classification that you may all be familiar with, this was developed by Earl Spalding in 1968, and it was a rational approach at the time for disinfection and sterilization of reusable medical devices. It was based on a risk of infection transmission associated with the use of a medical device. And it was also adapted by all reprocessing guidelines internationally. So this is something that's very common in the world. And so when you look at the chart down below, it's separated into three elements. Of course, the top one is critical, and this is when the devices will come in contact with sterile tissue. And so if we do utilize ultrasound equipment in a critical area with the client, if it's in the perioperative area, the ultrasound probe must be sterilized. So, and that means, of course, all viable microorganisms must be destroyed through the sterilization process. Semi-critical would refer to the ultrasound probes would contact mucous membranes or broken skin. And this would be when you're doing your endocavity probe or endorectal probe procedures. They're required to have high-level disinfection in order to remove viable microorganisms, except the bacterial spores. In that case, they would have to be sterilized. And non-critical devices, if you're performing an abdominal ultrasound on the client, well, then it's it's intact skin, so it's just a non-critical classification, and therefore those probes and the handles all require low-level disinfection. So the low-level disinfection requires a cleaning and a disinfection that would remove most vegetative bacteria, viruses, of course, except bacterial spores, fungi, or small non-lipid viruses. And so again, these are some of the most common ones that you would use for abdominal ultrasounds or in the intensive care unit if you're inserting an IV in some of the critical clients. So just a few words about the potential contaminants that can cause some cross-contamination. Everyone's familiar with HPV, the human papilloma virus. There are 100 types of this HPV grouping, and there are 30 that affect the genital area. So I guess one of the important pieces to note here is that when you're performing endocavity probe procedures, HPV, and there's over 100 types, as I said, but 18 and 16 are the most common causes of cervical cancer, and there's about a 70% chance of cervical cancer if these probes aren't reprocessed properly. There's two other viruses that would cause cancer as well, but 18 and 16 are the two most common. HIV can also be transmitted, hepatitis B and C, and we'll talk a little bit about some of that transmission internationally later on. And, of course, the general pathogenic bacteria. So if you don't perform the low-level disinfection on your handles, etc., then you can pass on bacteria through to the next client and yourself. So what is the definition for reprocessing? It's a set of decontamination sets undertaken to prepare a medical device for reuse and decrease the chance of cross-infection. So in order to do that, it's required that you have pre-cleaning at the bedside or the point of care cleaning. The cleaning method can be either manual or automated, as approved by the manufacturer, high-level disinfection, or sterilization. And so again, you have to refer to the risk assessment and which Spalding classification the device comes under. And then there's a table just to describe the reprocessing steps. And here we talk about pre-cleaning at the bedside. So whether it's yourself or a physician or another assistant, it's important that everybody is trained at how to perform the pre-cleaning at the bedside. Then you have to transport your device to a reprocessing area, and the device should be contained when you're doing that. Manual cleaning and or automated, but most often we use manual cleaning and rinsing. Then we move into the high-level disinfection. mode. Of course, the devices had to be rinsed thoroughly after high-level disinfection. They have to be dried thoroughly. Then there's an inspection process, and then you transport to a storage area, and of course, then the probes are stored. And I'm going to talk a little bit more about storage further on in my presentation. So cleaning, of course, we hear a lot about cleaning, and the Public Health Agency of Canada and Health Canada and all other guidelines and standards say that cleaning is obviously the essential procedure prior to any disinfection or sterilization. If you don't clean it, then it can't be disinfected or sterilized. That's a common saying, and we say, if it's soiled and if it's dirty, well, then you just can't clean it. You cannot high-level disinfect it or sterilize it. So everything has to be cleaned previously. Talking about if we don't follow our standards and our guidelines, then there could be possible transmission or cross-transmission to the client or to the employee themselves. But when you look at Canada, there has been some improper reprocessing of ultrasound probes in Canada. I know there's quite a few that are older. In the 1980s, there was one in Labrador with endocavity probes, and there's also been a couple in Canada, but a lot of these aren't widely publicized. I think most health care authorities in Canada look at the risk, and then they would decide on whether they provide disclosure to the clients. But there was one in 2017, or 2014 rather, from Saskatchewan, and Infection Prevention and Control in that province put out an alert to ensure that everybody was trained and properly and had competency testing done, and to ensure that they were following proper protocols and guidelines. And so it's just talks to how important it is to ensure that you're following these guidelines. And nobody goes to work not meaning to not perform properly, but everybody goes in, and you all have to make sure that you're trained. So it's very important that if you don't feel that you've been properly trained, that you ask to be trained. So what's happening in the U.S.? Well, there's a joint commission in the U.S. A lot of people have heard about AAMI and their accreditation processes through the joint commission. There has been some non-compliance through disinfection and sterilization of reusable instruments. They also released a safety alert on standards for instrument high-level disinfection and sterilization. And following that, they noticed that there were 74% of all immediate threat to life declarations were related to improperly sterilized or high-level disinfected equipment. Now, this could include other devices as well, but certainly ultrasound probes were included in that. And they noted that noncompliance has worsened in the Joint Commission accredited hospitals, in the critical care areas, ambulatory off-site offices, and the office-based surgery facilities. And we know we have a lot of these in Canada popping up in several provinces where there are some private clinics, so it's very important that everybody is informed and educated on the reprocessing. And I just wanted to mention one. John may mention some a little bit later, but certainly in the UK, there was a death from an improperly reprocessed probe. That was in 2012, and it was due to hepatitis B transmission linked to an intracavity ultrasound procedure. So hepatitis B infection was caused because of improperly reprocessed TEE probes, or a probe. And so, again, once the Infection Prevention and Control world identifies a cluster, or if there is any surveillance going on in the hospital and they notice a cluster of reports from the microbiology lab, they will go out and have a look and see what's happening and where these things are coming from. So you guys, some of you may have already been involved in some of that in your workplaces already. So there was an alert call for all facilities to review their intracavity ultrasound probe reprocessing policies. And as again, you can't speak to how important it is to ensure that everybody is competent in the procedures that they're performing. So to talk a little bit about current reprocessing guidelines in Canada, there are many, and most of these you may or may not be aware of. I think those of you who are sonographers or technologists in the ultrasound diagnostic imaging departments, you're certainly familiar with your own standards. But the Canadian Standards Association Medical Device Reprocessing Standards, it's a ZAD 314 series that sums up everything with regards to reprocessing of reusable medical devices. And then the accreditation standards are written based on the CSA standards, and there's also a specific standard on reusable medical devices reprocessing. In the infection prevention control standard, there is a section on the medical device reprocessing standards clauses, and there's also an MDR section in the diagnostic imaging standards. So if you don't have all three of those, it would be I would suggest it would be very important for you to have a copy and to review that and to ensure that you're meeting all of those. I know most of the larger health authorities in Canada do have accreditation processes occurring in their facilities every 3 to 4 years, and so it's important that you stay on top of those. Alberta Health Services has a provincial guidelines document that's available online, and so does Ontario. It's the PIDAC document, Provincial Infectious Disease Advisory Committee Best Practices. Likewise, British Columbia has a similar document, and the sonographers have a similar document, the Canadian Society of Diagnostic Medical Sonographers. So there's a lot of standards in Canada for us to available to us to ensure that we are meeting, providing safe patient care to our clients. Current guidelines and standards within the U.S., some of us work side by side with those, and we refer to those as well in our workplaces. So there's the American Institute of Ultrasound in Medicine. I'm sure the diagnostic imaging, the X-ray group would be familiar with this. There's a Center for Disease Control, the CDC, as it's more widely known. They have a guideline for disinfection and sterilization in healthcare facilities. Now, it's the document that's currently available is 2008, but they are revising that document, and it will soon be ready for distribution. So have a look for that in the next 6 to 8 months, and that is a good reference. Actually, it has been good, even though it's 2008, but it's still a very good reference. And then there's the AAMI. People hear about the AAMI standards out of the U.S., the American National Standards, and they have ethylene oxide sterilization in healthcare facilities, safety and effectiveness. So the AAMI standards, ST41 2008 and revised 2012, are certainly good references as well for you. So as well, we've got the Joint Commission High-Level Disinfection and Sterilization Booster Pack. That was developed in 2016. And the American National Standards this is a repeat, actually, of what I had on the other page. So that's just a repeat of that one. So just a few words about reprocessing of ultrasound probes, just to kind of bring it all together. Ultrasound probes are widely used in different clinical settings, as I've just mentioned, with different end users. And they require reprocessing of probes and the handles after every use in every setting. Nobody's excused from providing proper, safe patient care to our clients and to yourself to protect yourself. This will prevent infection transmission and ensure patient safety. There are heat-sensitive instruments, and these cannot undergo steam sterilization. Some equipment now that's being manufactured can undergo low-temperature sterilization. The ultrasound probes can't at this time, but there are transesophageal probes, and the bronchoscopes can go through the low-temperature sterilization. Some of them are also validated for steam. Require the use, so reprocessing ultrasound probes also require the use of a probe cover. And you also need to use ultrasound gels, obviously, to assist you with providing a patient care so that you're not causing too much discomfort, and also to aid in the picture that you will get on your ultrasound video machines. So probe covers it depends on the risk of the transmission of the procedure that you're performing. If you're performing an abdominal ultrasound, well, then you can use a general probe cover. It doesn't have to be sterile, but certainly if you're performing a procedure or assisting in the perioperative, in the OR, in critical care, some areas, you should be using a sterile probe cover. And with regards to gels, there's been a lot of documentation over the last 15 to 18 years on the risks of using multi-use gel containers. We recommend in Newfoundland, Labrador that you use single-use sterile gel. You don't use a multi-use gel container. If you do use a multi-use gel container, then you should be obviously wiping it down with a low-level disinfectant between each client and ensuring that you clean those, because you're picking it up with your hands, and then you may have gloves on your hands. You remove your gloves and you wash your hands. I haven't talked a lot about hand hygiene here, but certainly hand hygiene is performed before and after every procedure. The probe covers, I'm sure a lot of you are aware, can have micro tears, so it's really important to ensure that your disinfection is performed accordingly to the Spalding classification. And sometimes some physicians think that probe covers can help you to be able to do more procedures. You don't have to do the reprocessing, but that is false. And so, as all of you know, I'm sure that even though you use a probe cover, you still have to follow all of the procedures for reprocessing. So a little bit of news that's hot off the press is some of you may be aware, some of you may not, but the Canadian Standards Association has been working for the last 2 years to revise the CSA ZAD314 series of standards. So there's about 9 standards that I guess refer to or provide information on guidelines on reprocessing. It would be your general guidelines, your medical device reprocessing for reusable instruments, your sterilization, laundering, purchasing, transportation. So what we've been doing is we have been amalgamating all of the pertinent MDR standards into one. So it's a huge job, and the document is finalized. It did go out for public review in September, and the CSA group are editing and putting the document together. So it will be released in early 2018, and we've asked CSA to do some work on marketing and educating you guys, putting out some information on how that will be available to you. Some people talk about you do have to purchase these standards, but it's important. If you end up in a court of law and you're not following these standards and guidelines, well then, I'm sure they will be referring back to the standards, and so it's very important to keep up to date on the revised documents. Just to mention a few things, I can't get into the specifics, but there's improved wording to the ultrasound probe reprocessing. If the standards cannot be met within the department, who would be and where would you reprocess these probes? And there's also some specific information on the critical classification for intraoperative procedures and future purchases of these devices, as well as identification of the probes, whether they are soiled or if they've been high-level disinfected. So the labeling of the probes, and then of course the storage guidelines. So there's some improved storage guidelines that some of you may or may not like, but it's getting to be a little bit similar to the scopes in that. If you look into some of you go into some of the hospitals, many hospitals have a great protocol for storing their endocavity probes, and then others may not because of space limitations. So we're hoping that this standard will help you to obtain some proper space and cabinets for storing these and keeping them clean between use. So in general, what do the Canadian standards say? Ultrasound probes are complex, even though they don't have a channel, but they're still a complex device. They're very fragile, as we all know, and they're highly specialized medical devices that do require particular care in cleaning and handling. Prior to further reprocessing, all ultrasound All used ultrasound probes shall be cleaned. It's not a should anymore, it's a shall, so it's required with a validated detergent or in accordance with the manufacturer's instructions. So I haven't said too much about manufacturer's instructions. However, in adjunct to the standards, the manufacturer's instructions are critical, and it's important that those are reviewed and your protocols and policies are written based on the standards and the manufacturer's instructions. So ultrasound transducer probes that come in contact with any mucous membranes shall, at a minimum, be cleaned with a detergent and undergo high-level disinfection in accordance with manufacturer's instructions. There are very different types of high-level disinfection out there today, so you need to assess all of those and develop policies within your health organization, what is best for you and safest. The use of sheaths or your probe covers, they must be single use. They do not remove the requirement to reprocess reusable probes, and I did state that a few slides back. When an ultrasound probe may contact intact skin, it shall be cleaned and undergo low-level disinfection between each patient use, and of course, again, in accordance with the manufacturer's validated instructions. Ultrasound probes shall be sterilized. I'm going to take a drink of water here. When it enters or comes in contact with tissue, the vascular system, and sterile body cavities. So we all realize that and we're aware of it, but there are still some probes out there that are not sterilized when they're used in the OR theaters. We do use you may use sterile probe covers, but I do know that manufacturers are looking to develop probes that can be sterilized. Also, where a biopsy is being performed or considered, this is a point that I think is important to spend a few minutes on, because over the years, we've got the ultrasound probes. It's very easy access for physicians to want to have a video ultrasound machine in their departments for whatever they may want to visualize something. And so if they're performing biopsies, unfortunately today, there may be occurrences when these probes are not high-level disinfected if they're used for biopsy purposes. So you have to ensure, if you're working in these areas, that if the device comes in contact with blood or tissue or body fluids and it's an internal, enters the body cavity, then high-level disinfection is required. And I know in my acute care setting where I just recently retired that was something that the IPAC group were going to be looking at, because we know in the emergency departments that the probes are being used fairly widely in those areas, and they do become contact with blood. And so it's important to make sure that we're following those guidelines. So a reprocessing area, this is a very contentious issue for some people, but certainly when your area is audited, this will be identified that reprocessing areas shall be physically separate from the client service areas. It's common for the last 20 years that endocavity probes may be reprocessed in the client procedure room after the client leaves the room. However, the required standards now state that this reprocessing shall occur outside and away from the client service areas, patient treatment rooms, or clean storage areas. And your equipment should always obviously flow from dirty to clean. We know everybody doesn't have the perfect reprocessing area. The ideal would be that you'd have a separate decontam from where you will be high-level disinfecting, but if you don't, then you must work from dirty to clean. Reprocessing areas for high-level disinfection shall have adequate space for all reprocessing activities, including rinsing, proper airflow and ventilation in accordance with your occupational health and safety legislation. The sinks shall be large enough to facilitate the work, and there, of course, there shall be eye wash stations. So those of you who have been already audited will know that that's become a requirement. So it's really important. So we're hoping that these standards will help you obtain better work areas. Personal protective equipment, PPE, you have to protect yourself, of course, and your client, but certainly yourself. During cleaning and disinfection processes, proper PPE must be worn. And this will depend on what procedure you are performing, but fluid impervious masks with eye protection, a fluid resistant gown, a chemical resistant gloves, and a cap to cover your head. So if you look at the central MDR departments, everybody in those, the technicians, medical device technicians there work, and they always wear their PPE. Sometimes if you have many jobs and many duties, you may not take the time to wear your PPE, but it's becoming very important. It is very important, and you have to protect yourself. So you cannot wear the same. You have to have a cover up. You cannot be going from the patient into the reprocessing area with your uniform on. You have to wear a proper PPE as required. And do you have standard operating procedures developed? I suggest that those of you who are working in the X-ray departments or diagnostic imaging departments, or even if you're in a private clinic somewhere, consult the infection prevention control group. They can certainly help you develop your standard operating procedures. They shall be in place. That's new wording, that you shall have documents and procedures in place for reprocessing ultrasound probes. The procedures shall be consistent with the manufacturer's instructions for reprocessing, and also the CSA and all the other standards, of course, that we have in Canada. And they shall cover the following reprocessing steps: pre-cleaning at the bedside, transporting to the reprocessing area, manual cleaning and rinsing, high-level disinfection, rinsing after high-level disinfection, drying, inspection, transporting to the storage area, and storage and documentation. So documentation, some of us have electronic documentation, but it's written in there, our standards, that we have to be able to trace, or if there is a breach or a possible breach and you're investigating something. And as I said, with regards to the storage, it will be important for you to obtain the new CSA standards, because we are requiring the storage of endocavity probes in a HEPA-filtered cabinet. There's been a lot of discussion on that out through Canada when the public review went out for the document. But we are seeing this requirement in the U.S., and we want to ensure that we give those of you who work in these departments some, evidence and basis for obtaining proper storage areas when you're requesting them. Reprocessing areas are generally very small, and so it's important that we maintain a safe environment there. Personnel education and training. So again, I can't emphasize enough the ongoing education. Training the trainer is not the proper way for educating somebody today. You must require education and training from the manufacturer. And there should be some people who are trained in the department who can provide the training to other employees as required. And it would be, I would suggest that you involve, if there's an educator in your health facility, or if you're in an off-site office area, a private clinic or a physician's office somewhere, ask for the specific training and develop your standards, and then you will be able to ensure that you give consistent training to these employees. And because you've heard the old adage that if you tell a story to somebody 10 times, by the time that story gets to the 10th person, it's possibly different, and many steps are missing. So it's really important to ensure that proper education and training is provided. And it shall be by a qualified person. Competency training at regular intervals. If you have permanent staff, you can decide yourself how often you would feel that competency training is important. I know we developed our competency training for permanent full-time employees every 4 months, and anyone who was casual or was on an on-call basis came into a department where there was reprocessing. We would look at the number of shifts that they would work there, and these people might require competency training every month. It will depend on how often they perform the procedure. And it's important, of course, to apply the principles of infection prevention and control always to decrease the risk to both patients, clients, and staff during any routine reprocessing procedures. And in summary, I just want to, review what I've said, is that there is recent evidence that suggests improper reprocessing of ultrasound probes globally. What you can't see and what you don't know is very important. So it's very important that we all support the standards and ensure that you educate your managers and your supervisors and your whoever in your department or in your health authority that you need to ensure that they see the evidence that you need to follow proper protocols. Ensure your department or your facility has a reprocessing protocol for ultrasound probes and keep them up to date. Ensure that high-level disinfection methods that you use are shown and validated to have activity against the HPV, human papilloma virus, for vaginal and rectal probes, and that they comply with the CSA standards. For a number of years, I think there was a group within the healthcare organizations that felt that HPV could be transmitted through vaginal and rectal probes, and as well some GI endoscopes. But it didn't become widely known until the last 2.5 years, when there's been some more research. And Michelle Alpha, our Canadian researcher, who just recently retired, she has actually reviewed some of the articles and the publications and has concurred that it's very important to look at what process you are using and to ensure, if you don't know, ask the manufacturer if the product that you're using has been validated to have a efficacy kill against the HPV. So that would be a very important takeaway note. And current guidelines prefer validated and automated reprocessing methods. For many years, and we still do, and we will for years to come, perform manual cleaning and disinfection methods. However, anytime you have a manual method, then you have a risk for errors. We're humans. There's a human factor that comes into play there. And as I said, nobody ever comes to work with the intention of missing out on a few steps or making errors. So if you can purchase or recommend purchasing automated reprocessing methods, then you know that the procedures will all be followed accordingly, and you will hopefully have some data or printouts that you can utilize to ensure that you did meet those guidelines. So that's a very important point as well. And, of course, ensure that you have training and ongoing competency. As I said, what you don't know can hurt you, and so it's very, very important. And I'm talking to, I'm sure, the converted, but it's very important and good to have a review sometimes. And I certainly thank Nanosonics for this first Canadian webinar, and I hope that we will have some further ones that we can delve a little bit more into some of the guidelines and the standards. So thank you very much.
So thank you very much, Melanie. That was great. Really appreciate you presenting today. So there are some questions coming in as the presentation is proceeding, and we'll pause at the end to answer those together. So we'll now move on to the second presentation today. So I'll just give you a little bit of background about myself before I start. So I'm currently Head of Clinical Affairs at Nanosonics, company specializing in medical device reprocessing and infection control. My team and I work internationally in the area of ultrasound reprocessing, and going to share with you a little bit today about some of the things that are happening around the world. And I think kind of a bit of a new frontier in this area, and that is really semi-critical and critical surface probe procedures. So my background, I have a PhD in biochemistry and molecular biology, and I've worked in a number of different academic and commercial research settings, and I've also worked in medical microbiology and environmental microbiology. So today, I will be speaking about practical considerations for reprocessing workflows in ultrasound. So before I get started, because I am from a company, I do need to just give you this disclaimer. So firstly, to disclose to you that I'm an employee of Nanosonics, and the company manufactures and sells a device for ultrasound probe disinfection. We won't be talking specifically about the product today, as this is an educational presentation. Essentially, this disclaimer just says, basically, do your own research. Best efforts have been made in putting these slides together. But basically, you should follow up and check documents and so on yourself. So I'd like to get underway. So practical considerations for reprocessing workflows in ultrasound. So I think, there are a few things that have happened in recent years. So ultrasound technology has really proliferated throughout healthcare. And if we think about sort of 20 years ago, the frequency of ultrasound being used to guide a central venous catheter placement was very low. And these days, it is much more common. So we've seen ultrasound be used to guide a lot of invasive procedures. It is a low-risk imaging modality versus radiological-based imaging techniques. And so it's also very convenient, and it improves clinical outcomes. I think we should always remember that ultrasound brings great clinical benefit. There is just this little catch that obviously there are some infection control risks with its proper use. So because ultrasound has expanded so widely, managing and maintaining standard probe reprocessing workflows can be difficult. And it's very important to think about these factors when we're trying to make this practical and implement, select products and procedures to implement. So I just wanted to run you through some different examples of sort of what not to do here. So here we have a kidney biopsy. We have no probe cover on this probe. We have non-sterile gel, and the puncture site is contaminated with the gel prior to the biopsy as the physician or sonographer is searching for the appropriate location. Biopsy needle then passes through the gel and traumatically implants contaminants into a person's organ. And we know from a number of studies that various microorganisms have been isolated from gel, things like extended spectrum beta-lactamase expressing Klebsiella pneumoniae, Pseudomonas aeruginosa, Staphylococcus aureus, and we'll talk in a moment about some recent outbreaks in this area. So, of course, what you should do is use sterile gloves. This would be a sterile field procedure. You should use, obviously, sterile gel and a sterile probe cover, and you need to reprocess that probe appropriately as well. So if we look at the steps involved in central line placement, we can see that the patient is scanned a number of times. So they're scanned at the beginning to select an insertion site. That would typically be considered a non-critical ultrasound scan, so a non-critical procedure because it contacts only intact skin. And that probe should be low-level disinfected before that scan. But then the insertion is planned and the location is selected, and then the skin asepsis occurs. And at that point, that probe then needs to be minimally high-level disinfected or preferably sterilized, and then it can be used to guide the placement of that catheter. And we'll get to why this is so important on the next slide. But you can see from a logistics point of view that that's quite difficult. So, you need to decide whether you're going to reprocess that probe between the preliminary scan and the placement scan, or whether you're going to have multiple probes available that you can take from storage to do this. So there are a number of central catheters. Two are pictured here, a tunneled central venous catheter and a peripherally inserted central catheter, and there are other central catheter examples as well. But so what makes this so important is that this year there have been 2 outbreaks associated with the placement of these central catheters. So earlier in 2017, and this is published in AJIC, the American Journal of Infection Control, 10 patients developed septicemia with Burkholderia cenospacia, and they underwent ultrasound-guided central line placements. And it turned out that the gel that was being used, and this gel was part of a central line bundle, the gel was actually contaminated with organisms. So it was supposed to be sterile, but it was contaminated. And so, like I said, 10 patients ended up developing bloodstream infections, which is obviously a very serious outcome. And then 2 months later, a similar outbreak occurred in Saudi Arabia, and 14 patients were infected. It was actually the same organism, and unfortunately, in this case, it resulted in 2 patients actually dying as a result of those infections. So although this is obviously concerned primarily with gel, the point here is that the gel, the probe cover can all contact the puncture site, or at least be proximal enough to the puncture site to cause an infection via that central line. So this highlights the necessity to use sterile gel, sterile covers, and preferably a sterile probe or at least a high-level disinfectant probe. So quite a lot has happened this year. In October, the organisation Health Protection Scotland, which is a government-funded agency in collaboration with the NHS Scotland, so that's the Public Healthcare Authority in Scotland, ran this study. So Merle mentioned earlier that a patient had died in 2012 from a transesophageal ultrasound procedure. And this kicked off a review in the UK of ultrasound probe reprocessing. And a number of countries have since brought out guidelines requiring high-level disinfection for endocavitary probes. The Scottish guidelines only came out in 2016. And prior to 2016, people were actually broadly performing low-level disinfection of endocavitary probes. In fact, in a survey in 2012, only 9.5% of Scottish NHS hospitals were actually performing high-level disinfection of endocavitary probes. So this particular study looked at the association between endocavitary probe use and positive bacterial cultures and antimicrobial prescriptions in the 30 days following a scan. And so basically during the study period, the predominant method of reprocessing was low-level disinfection. Of course, that would be inappropriate in most Western countries and Scotland today. And so what the authors found when they compared the control group who did not have ultrasound, and they were matched patients, they were, for transvaginal, they were OBGYN patients who did not have ultrasound, they found that patients undergoing transvaginal scan were 41% more likely to have positive cultures and 26% more likely to be prescribed antibiotics in the 30 days following a procedure. And it should be pointed out that the prescription of antibiotics and the ordering of those cultures was typically done by the primary healthcare provider and not necessarily done by the same site that had performed the transvaginal ultrasound, i.e. the hospital. Similar picture with a transrectal scan, but with even greater increased risk. So this is the first study that has really explored this in a lot of detail, and I think underscores the need to perform high-level disinfection of these endocavitary probes. So I guess we've talked a little bit about surface probe procedures such as line placements, and we've talked a little bit about endocavitary procedures. But really, there is a bit of a contrast here. So for an intracavity procedure, you do have considerable complexity from an infection control standpoint. You have quite a number of departments performing these procedures in let's say, an acute care hospital. The variety of procedures, there are quite a number of different procedures. I mean, for instance, in a fertility setting, you might be conducting, follicular assessments with transvaginal ultrasound, but you may also be conducting oocyte retrieval procedures, and they're obviously quite different from an infection control perspective. There are quite a number of individuals performing those scans and performing reprocessing at different locations. So all of this adds up from an infection control perspective to quite a complex problem. But unfortunately, it gets a lot worse when we move across into the surface probe area. Surface probes are used in semi-critical and critical procedures in a very large number of departments across the hospital. They're used in a wide variety of procedures by a wide variety of people. They're reprocessed in all kinds of different settings. And really, from an infection control perspective, this surface probe issue is quite a challenge. So I've just shared a brief list of procedures here that could be considered as being semi-critical or critical that involve surface probes. So I've kind of grouped them into various categories, and this is certainly not an exhaustive list, but all biopsies where there's a chance that the surface probe could contact the puncture site, all injections, ablations, surgeries. I mean, in the injection category, probably something like a nerve block would be a very common procedure where there is a chance that the probe could contact punctured skin. Catheterization and cannulation, vascular access would be one of the most common groups of procedures there. And then aspirations and drainages. Because ultrasound technology has improved so much and it's become widely available, it's very common to use ultrasound to guide these procedures. So Merle mentioned some of the local guidelines in Canada and in passing some of the US guidelines, but I just thought I would share some of these with you. So the AIUM, the American Institute for Ultrasound in Medicine, and CDC 2008, both specifically address ultrasound probes and agree that semi-critical and critical probes must minimally be high-level disinfected, and that critical probes should be preferentially sterilized. And then there are similar requirements about medical devices more broadly from the FDA, AAMI, and the Joint Commission. And if we look internationally, again, this year there has been a lot of activity in this area. So in Scotland, last year, we saw new guidelines out, but since then, Ireland has released guidelines, the British Medical Ultrasound Society have released guidelines, the European Society of Radiology have released guidelines, and also ACIPSI, which is the Australasian College of Infection Prevention and Control, have released a joint guideline with ASIM, Australasian Society for Ultrasound in Medicine. So this is the world first joint guideline in Australia, a collaboration between both the infection control experts and also the sonography profession. So all of these guidelines essentially agree, and they are in line with Canadian and US guidelines as well, and that is that semi-critical and critical ultrasound probes should be minimally high-level disinfected, and for critical probes, they should be preferentially sterilized. So just bringing all of this together, it's quite a challenge for an ultrasound end user to grapple with the Spalding classification in a real world setting. So, that person needs to think about what the upcoming use of the probe will be and what tissues it will contact, and to categorize that probe based on the risk of contact with these tissues. So if the probe is only going to contact healthy intact skin, then that would be considered non-critical and could undergo low-level disinfection prior to use on the patient. If the probe were to contact mucous membranes or non-intact skin, so that would be all endocavitary procedures, procedures where there was a rash, procedures, scanning partially healed wounds and so on, that device would be considered semi-critical and should be minimally high-level disinfected. And then if the probe contacts sterile tissue or enters sterile body cavities in the vascular system, so for instance, used in surgery, intraoperative procedures, drainages, biopsies, and so on, there are some slight variations here regionally, but essentially those procedures would be considered broadly critical in most countries, and those probes should preferentially undergo sterilization. In many guidelines, there is an option if the probe cannot be sterilized, and that's usually due to material compatibility issues, then high-level disinfection and use with a sterile sheet is acceptable. But that, like I said, that depends on the specific country's requirements. So the guidelines internationally are quite consistent on this issue, but the larger question is, are they being followed? So last year, we assembled a group of infection control professionals in the United States, and you can see here their names are listed below. Most of them are infection control directors with large systems in the US. And we reviewed some preliminary survey data with this group and discussed some issues relating to ultrasound reprocessing. The proceedings of that meeting were published in ICT, and if you have time, I'd urge you to take a look at that article. But one of the things that really came out of this meeting was the need for better data on compliance with reprocessing for particularly semi-critical and critical surface probes. And so we decided that we should conduct a survey. So this survey has been run by the University of Louisville and is led by Professor Ruth Carrico. And the survey has recently been conducted, and we're planning to write this up and submit it soon. But I just wanted to share some of the preliminary results with you. So these results were presented at the SDMS, Society of Diagnostic Medical Sonographer meeting in the US in October. So one of the questions we asked people is where in the hospital is ultrasound used? And you can see there's a crosswalk of a number of different departments here. You can see that the vast majority, well, in fact, all of these departments, we have reported some ultrasound use depending on the specific respondent. But I think this just highlights how broadly ultrasound, has proliferated to these departments. And I think from an infection control perspective, many infection preventionists would not be fully aware of the spectrum of ultrasound use across facilities. So we asked the respondents about their specific reprocessing practices. What we found was that with endocavitary procedures, such as transvaginal ultrasound in this instance, we found that the majority of respondents indicated that the procedure was done in their facility and that 92% performed high-level disinfection and 5% performed sterilization. So the vast majority of people appear to be essentially complying with the guidelines, and the vast majority also used a sheet and single-use gel. But from there, it sort of really deteriorated. So if there was a scan across non-intact skin, around half of the respondents performed low-level disinfection and around half HLD. 18% of respondents didn't use a sheath and 24% used multi-use gel. If we look at vascular access for central venous catheters, this is where I think this really gets quite shocking. The majority of people did not perform high-level disinfection or sterilization. Most did use a probe cover, and often that was sterile, but there's a significant number of times it was not. And then, again, 70% used sterile gel, but that leaves 29% using non-sterile gel. And I think the thought of a needle going into someone's vascular system through non-sterile gel is very concerning from an infection control perspective. So for peripheral lines, we saw a worsening trend. There was an increase in the amount of low-level disinfection conducted and an increase in not using a cover or not using a sterile cover. And we also saw an increase in multi-use gel bottles and single-use clean gel, which would not be appropriate for an invasive procedure such as this. So biopsies were a similar picture. There's maybe a slight improvement here with this single-use sterile gel and the sterile cover, but still broadly a lot of non-compliance. Nerve blocks, again, we saw a similar situation. But where things were quite different was with intraoperative probes, and of course the OR nurses are being involved here, and being very dedicated to appropriate disinfection and sterilization, infection control practices, we found that 93% of people use a sterile cover in this instance. The majority were performing high-level disinfection or sterilization of these probes, and 95% reported single-use sterile gel. So the picture in the intraoperative setting is much better than it is in some of the other departments. This is an Australian study that looked at emergency departments and ICUs in 5 hospitals, and they found that blood was contaminating the majority of ultrasound probes, ultrasound probe cables, and consoles. In fact, 57% of probes were contaminated with blood, and they used a hemoglobin detection kit, and only half of these had visible blood on them, so they had microscopic levels of blood in many cases. Half the probes were contaminated with bacteria, and none of these EDs and ICUs had any probe disinfection policy. So I think in the critical care segment, there's really an urgent need to address some of these issues. Traditionally we think about high-level disinfection of endocavitary probes, and that is quite well understood. But as the use of surface probes has expanded, there's a large variety of procedures across many departments which need to be addressed. So I think I just made this point, but these steps really rely on collaboration between various stakeholders here: infection preventionists, medical device reprocessing experts, and sonographers and physicians. So I just wanted to leave you with this last slide. What should one do to tackle this problem? I think the first thing to do is to locate the ultrasound devices within your facility. Talk to your colleagues, find out who is using ultrasound, perhaps go to your biomedical engineering department and see if you can find a list of ultrasound assets, and then work together with the departments to understand what procedures are being done and what the current approach has been. Stay informed, look to the new CSA standards, which Merle mentioned are coming out in 2018, and make sure that you've read the IFUs of the probe and any products that you're using in association with that probe. And I think also, leadership and training, it's well and good to have a policy, but actually making sure that people are carrying that out is critical. And I just wanted to leave you with one last piece of advice, and that is to leverage the advice of the vendors to address ultrasound reprocessing questions. So you can ask questions of the ultrasound manufacturers, you can ask questions of companies like Nanosonics that provide products into this area, and really, feel free to lean on those people for additional information. So thank you very much for your time. I can see we've run a little bit over time here with the presentation. We did just want to launch a quick survey here to get some feedback from you on the presentation. I think we'll have time to answer a couple of questions, but we'll just send that survey out to you now. And if you could start answering that would be fantastic. So that has gone out, so you should see that come up on your screen. If you could answer that would be very helpful. While you're answering that, I'll just switch to some questions. So, Merle, I might pose a question to you. So we've got quite a few questions coming in here. The first question here is, what about storage of ultrasound probes? Do you have any advice for people on how to appropriately store their probes?
Yeah, so that will be actually written clearer in the 2018 standards, but so I know they should be, obviously they have to be dry, and you should have a separate cabinet. We're recommending it'll be recommending a HEPA filtered cabinet. So there are some companies in the U.S. that sell these cabinets. Currently, if you don't have that, then they should be absolutely dry and in a room that's separate from your reprocessing area. So that's the ultimate goal, is to have them hanging, and you can't, like, gone are the days when you can have a biomed or somebody making those cabinets. You have to have a cabinet that can be cleaned and doesn't harbor, won't harbor microorganisms. So the recommendation would be to hang them appropriately in a HEPA filtered cabinet.
Fantastic. Thank you, Merle. So in terms of the survey response, the 3 options were yes, no, or unsure. the question was the content in this webinar new and or useful to you? So we had 94.83% say yes, 3.5% say no, and 1.72% say not sure. So thank you very much for your feedback. It's very helpful to us. I'll go to a second question now. There's a question here. Vaginal probes, is simple wipe and probe cover sufficient? Physicians state that the device is inserted inside of the speculum, thus is not in contact with mucous membranes. Thoughts? So I'll have a go at answering this. I think the vast majority of transvaginal ultrasound procedures are done without a speculum, and so you would certainly expect contact with the vaginal wall during the procedure. If a speculum is used, you are still going to need to have the end of the probe contact the vagina in order to resolve an image. If there's any air gap between the end of the ultrasound probe and the tissue, then you'll essentially get a lot of scatter. So even if a speculum was used, that probe would still need to contact the vaginal wall or the cervix in order to visualize the anatomy there. So Melanie, we might just do a couple more questions. I'll just propose some to you here. So we have another one. Do we have to use a cover for abdominal ultrasound on healthy skin?
No, you don't need a... so, you know, in general, I mean, it wouldn't hurt. It doesn't hurt, but it's not a requirement. So if it's if it's totally intact skin, then you do not need to use a probe cover. Some people may choose to use probe covers, but it's not a requirement.
Sure. And we have another question here. What about putting the probe in a box to cross the corridor to go to the disinfection room? I think that person is probably just asking what are the transport requirements if one was to transport a probe.
So every department should have adequate numbers of transport containers. There are some companies who sell specific containers with, and then you can also purchase liners that will identify the probe as contaminated. You know, you'd put a red covering over the top when they're contaminated, and then you can walk them across. Then once they're sterilized or high-level disinfected, there's a green cover that you can put over the top until you know, when you're taking it into the procedure room the next day or the next during that afternoon. So you can purchase these. I mean, people do. I know people purchase them from Walmart stores and different variety stores, but as long as it's big enough for the ultrasound probe and its cable, and you're not coiling it too small, you know, you have to make sure that you're taking care of the equipment itself and that you don't damage it. So it's very important. It's better for you to have it in a container and cover it and walking across the hall than walking with it in your hands, because the risk of hitting it off a doorway or something like that. And then, of course, you're exposing yourself and others to a contaminated probe.
Brilliant. Thank you, Melanie. We don't have a whole lot of time left here because we've sort of run over, but perhaps we can just ask one more question. For those questions that we haven't gotten to, we can respond via email to those. So, Melanie, there's a question here for you. In your summary, you say that current guidelines prefer validated and automated reprocessing methods. Which standards are you referring to, and what do you mean by prefer? Is that a requirement or a recommended practice? And do all probe manufacturers validate and endorse automated reprocessing?
So no, not all. There are not a lot of automated reprocessing methods out there. In our new standards, we do recommend that you utilize validated, obviously, processes, but automated reprocessors or reprocessing methods will ensure your department is using the same method all the time. And I guess I refer to the human factor, that when something is being performed manually, and as I said, we all come to work today, and nobody means to forget a step or to make an error. I'm a registered nurse. I never go to work expecting to make a med error, but it can happen to us. So the more automated processes you have, the less chance of having any errors or omissions and breaches in your processing. Now, that being said, there would be checks and balances that would need to be put in place if you utilize automated reprocessing methods as well.
Sure, very, very helpful, Melly. So look, we'll wrap up there. So thank you very much for presenting for us today, and thank you to everyone who has attended the webinar. We will answer the additional questions via email in the coming days. So thank you very much. So we'll sign off there, and have a good evening, everybody. Thank you.